Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO! Hi, Pod Crew. In our last episode, we discussed diagnosis and management of early-stage epithelial ovarian cancer. Today, we'll be discussing management of advanced-stage epithelial ovarian cancer. Maya, what are our learning objectives for today?
Our learning objectives are to discuss the importance of surgical debulking in advanced epithelial ovarian cancer, to discuss the utility of lymphadenectomy in advanced epithelial ovarian cancer, discuss the rationale for the recommended upfront therapies for advanced EOC, including carbotaxol plus minus Bev and then plus minus Bev maintenance, and discuss historical trials, to talk about alternative chemotherapeutic regimens and options in the management of upfront advanced EOC, to discuss the utility of bevacizumab in the management of upfront EOC, to discuss the role of neoadjuvant chemotherapy in advanced EOC, and to discuss the use of PARP inhibitor in the management of advanced EOC, including recent updates to FDA recommendations and guidelines. We've got a lot to cover today, so let's get started. Sydney, do you want to open up our discussion of surgical intervention for ovarian cancer?
Absolutely. The most important thing to remember about surgical cytoreduction for ovarian cancer is the least possible residual disease at completion of surgery portends the best prognostic result. Optimal cytoreduction is defined as less than 1 centimeter of gross residual disease in any single location or implant, and an R0 cytoreduction is reduction to no visible or gross residual disease. Retrospective data demonstrate that the difference between these two categories is significant in terms of overall survival, and that both have better prognosis than suboptimal debulking. Therefore, gynecologic oncologists tend to be aggressive with their debulking surgeries. Sometimes these surgeries can involve bowel resection, diaphragmatic stripping, splenectomy, partial cystectomies, partial hepatectomies, and partial gastrectomies, among others. These extensive and radical procedures are associated with improved overall survival for patients, and thus they should be completed if feasible and if the patient can tolerate them. Preoperative counseling and expectations are important here. It's also okay to ask for help from your surgical subspecialists if you're doing a debulking that requires a procedure with which you're not comfortable. You may even learn how to do it in the process.
Most of our data on ovarian cancer debulking and degree of cytoreduction is retrospective. There have been several meta-analyses that have shown that lack of residual disease after primary surgery is the most important prognostic factor, regardless of the radicality of surgery performed. Said another way, if you can get optimal or R0 cytoreduction, patients will do better long-term, even if they have increased surgical morbidity in the short term. Because of the retrospective nature of the data supporting this, surgical debulking is not a Category 1 recommendation by the NCCN.
There are several upfront trials designed for other purposes which have shown a benefit to cytoreductive surgery in their subgroup analyses. These include GOG 172 and GOG 182/ICON 5. In these studies, subgroups with an R0 cytoreduction have demonstrated improved survival by greater than 24 months compared to patients with residual disease. Maya, I have a question. If I have a patient with advanced disease, do I need to do a lymphadenectomy? It wouldn't change the patient's staging necessarily, so is it still needed?
Sydney, what an excellent question. The authors of the Lion trial had a similar question. Prior to the study, Panici et al. Published a randomized controlled trial in 2005 with 427 patients. They were randomized to systematic lymph node dissection versus removal of bulky lymph nodes alone in optimally debulked advanced stage epithelial ovarian cancer. This trial showed improved staging accuracy, but no oncologic benefit to systematic lymphadenectomy, but it did show increased surgical morbidity. Conversely, a retrospective analysis of 3 trials suggested an overall survival benefit with systematic lymphadenectomy in completely debulked advanced stage epithelial ovarian cancer. Other retrospective meta-analyses also suggested a benefit in overall survival with systematic lymphadenectomy. Given the conflicting data, the authors of Lion designed a randomized controlled trial of patients with stage 2B to stage 4 epithelial ovarian cancer with clinically negative lymph nodes and complete surgical resection to pelvic and periaortic lymph node dissection versus omission of lymph node dissection. Microscopic metastases were detected in 56% of cases where lymphadenectomy was performed. However, there was no difference in PFS or OS between the patients who did and did not have a pelvic and periaortic lymph node dissection. Surgeries were longer, with higher blood loss and transfusion rates in the pelvic and periaortic lymph node dissection group. Additionally, repeat laparotomy, readmission, and death rates within 60 days of surgery were higher in the pelvic and periaortic lymph node dissection group. In conclusion, this randomized controlled trial established that systematic lymphadenectomy for patients with advanced stage EOC does not improve outcomes and shouldn't be done, even though it does detect some microscopic metastases. One caveat does exist, which is that bulky lymph nodes should be resected in all patients, if surgically feasible, as with all other bulky disease. Okay, this is making sense. I've heard that all patients with advanced epithelial ovarian cancer need adjuvant treatment with chemotherapy. Can you tell us more about the chemotherapies that we use?
I'm happy to. In this episode, we'll discuss standards of care for upfront treatment of advanced epithelial ovarian cancer, but we won't go into HIPEC or intraperitoneal chemotherapy during this episode. We do want to emphasize that HIPEC can be considered for patients with stage 3 disease at the time of interval debulking surgery following neoadjuvant chemotherapy. Much more to come about that in our separate episode about HIPEC and intraperitoneal chemotherapy. So Maya, what do we know about systemic chemotherapy at this point?
There are decades worth of randomized controlled trials that have been conducted evaluating different chemotherapy regimens for advanced stage ovarian cancer, and it's impossible to cover them all in a single episode. We want to cover some of the game changers. The big picture is that after many different trials with many different iterations, carboplatin and paclitaxel dosed every 3 weeks emerged as the preferred regimen for advanced high-grade epithelial ovarian cancer. No other regimen has shown significantly improved overall survival, and other options have different and sometimes less well-tolerated side effect profiles. We'll talk more about bevacizumab in a little while, but this is the only other thing that's recommended as a possibility for primary therapy as a first-line preferred regimen by the NCCN.
Let's turn back the clock and talk through some of these trials that got us to the carboplatin paclitaxel standard of care today. Historically, like in uterine cancer, cisplatin was used instead of carboplatin. In ovarian cancer, cyclophosphamide was used in combination with cisplatin. In 1998, ICON-2 was published. It compared single-agent carboplatin versus cyclophosphamide plus adriamycin plus cisplatin, the CAP regimen, in advanced epithelial ovarian cancer. There was no difference in overall survival, and CAP was significantly more toxic. The investigators thus reported that single-agent carboplatin was safe and effective. 2 years prior, in 1996, GOG 111 was published, comparing cisplatin plus cyclophosphamide versus cisplatin and paclitaxel in advanced epithelial ovarian cancer with post-surgical residual disease. The cisplatin paclitaxel arm was found to have an improved progression-free survival and overall survival. In addition, more patients completed the cisplatin and paclitaxel arm, despite the side effect of increased alopecia with paclitaxel. 4 years later, the results were confirmed by an additional RCT with identical experimental groups called the intergroup trial, cementing cisplatin and paclitaxel as the new standard of care. In the same year, 2000, GOG 132 was published, which compared single-agent cisplatin versus single-agent paclitaxel versus cisplatin plus paclitaxel in patients with suboptimally debulked epithelial ovarian cancer. They found that cisplatin alone or in combination with paclitaxel had improved progression-free survival compared with paclitaxel alone. There was a better toxicity profile with combination therapy. Overall survival did not differ between groups.
Taking together the results of ICON-2, which established carboplatin as a safe and effective agent, and GOG 132, which showed cisplatin and paclitaxel to have improved progression-free survival compared to single-agent Taxol, as well as a better toxicity profile compared to single-agent cisplatin, GOG 158 was designed. This randomized controlled non-inferiority trial published in 2003 compared carboplatin and paclitaxel versus cisplatin and paclitaxel. It enrolled about 800 patients with optimally resected advanced epithelial ovarian cancer. Progression-free survival and overall survival were not statistically different. There were worse GI, GU, leukopenia, and metabolic toxicities seen with cisplatin. However, thrombocytopenia was worse with the carboplatin regimen. Neurologic toxicities were similar. In the trial, the carboplatin was dosed with an AUC of 7.5, which is higher than our AUC range of 4 to 6 used today. Ultimately, and importantly, this trial led to the establishment of the combination of carboplatin and paclitaxel being standard of care for first-line treatment of advanced epithelial ovarian cancer. Cisplatin can be considered as an agent should a patient have severe or persistent thrombocytopenia. But Sydney, what do I do if my patient has debilitating peripheral neuropathy and can't tolerate paclitaxel?
Good question. In 2011, the results of MITO-2 were published. This trial compared carboplatin plus liposomal doxorubicin versus carbotaxol. There was no difference seen in progression-free survival or overall survival between the two arms. However, the toxicity profiles were different. In the carbodoxol arm, patients experienced less neurotoxicity and alopecia, but had more hematologic adverse events. Reported quality of life between the two arms of the study was the same. This established the combination of carbodoxol as a reasonable alternative to upfront treatment of advanced epithelial ovarian cancer. But that's not all. In 2004, Scott Rock 1 was published. It was a phase 3 randomized trial of docetaxel plus carboplatin versus carbotaxol as first-line chemotherapy in patients with stage 1C to 4 epithelial ovarian or primary peritoneal cancer. 1,077 patients were included. Patients in both arms were administered 6 cycles of chemotherapy, and at a median follow-up time of 23 months, progression-free survival, overall survival, and objective tumor response rates were not different. Docetaxel and carboplatin had significantly less overall and grade 2 or higher neurotoxicity, but did have significantly more grade 3 to 4 neutropenia and neutropenic complications. Quality of life assessments were similar in both arms. So voila, you have another 2 options for treatment, especially in patients whose treatment plans require tailoring to side effect profiles. Have we looked at any other chemotherapy combinations?
Yes. Additional trials have compared carboplatin and paclitaxel to other non-doublet combinations. ICON-3 was published in 2002 and compared carbotaxol versus a control of either cyclophosphamide and adriamycin and cisplatin, the CAP regimen, or single-agent carboplatin. Recall that single-agent carboplatin was determined to be non-inferior to the CAP regimen in ICON-2. ICON-3 included patients with stage 1 disease in addition to more advanced disease, with the criterion for stage 1 that the physician would be, quote, certain that the patient needs chemotherapy, unquote. Interestingly, this trial showed that single-agent carboplatin and CAP were as effective as carbotaxol. It's worth noting that about a third of patients on the single-agent carboplatin in the control group went on to receive a taxane at some point with or without platinum, mostly when their disease had progressed. Carbotaxol was associated with more alopecia, fever, and sensory neuropathy than carboplatin alone, and CAP was associated with more fever than Taxol and carboplatin. Despite the study results showing equivalent outcomes and a more favorable side effect profile of single-agent carboplatin versus carbotaxol, the doublet combination remains the standard of care. In an editorial by Oesch, who's the author of GOG 158, they posited that several randomized controlled trials, including GOG 111, OV 10, and GOG 158, have shown the importance of Taxol in combination with a platinum compound. The included patient population in ICON-3 was not nearly as well defined as in these other studies. In subset analyses of patients that had 0 to 2 centimeters of residual disease in ICON 3, there was a trend in favor of treatment with the doublet, which would be in agreement with the result of GOG 111, in which patients that had stage 3 or 4 suboptimally debulked disease had a decreased hazard ratio for death of 0.6.
In 2009, GOG 182/ICON 5 was published to answer the question of whether adding a third agent to carboplatin and paclitaxel improves outcomes. There were 5 arms in total, 4 experimental arms to test addition of an agent to the doublet, plus 1 control arm of the carbotaxol doublet. The experimental agents included pegylated liposomal doxorubicin, topotecan, and gemcitabine in 2 dosing regimens. There was no improvement in progression-free survival or overall survival in any of the arms.
So it sounds to me like carbotaxol is still the standard of care, with carbo and liposomal doxorubicin or carbo and docetaxel as alternative options in select cases. Have there been any studies which look at alternative dosing regimens?
Yes, there have been. JGOG 3016 was published in 2009 by Kasumata et al. The study looked at weekly dose-dense Taxol dosed at 80 milligrams per meter squared per week with carboplatin AUC of 6 given every 3 weeks versus carbo and Taxol, the Taxol being 180 milligrams per meter squared at standard every 3-week dosing. The dose-dense chemotherapy regimen was toxic. 36% of patients discontinued treatment early, and of these, 60% of discontinuations were due to hematologic toxicity, compared to 43% of discontinuations in the conventional regimen. This led to there being a relatively lower dose intensity of carboplatin in the dose-dense group compared to the standard regimen group, while the dose intensity of Taxol was higher in the dose-dense group. Despite marked toxicity, which led to higher rates of treatment reduction and discontinuation, the dose-dense therapy significantly improved progression-free and overall survival, with a PFS of 28 versus 17 months and a 3-year overall survival of 72 versus 65%. Long-term follow-up in 2013 was consistent with the 3-year results. In 2014, MITO-7 attempted to corroborate the results seen in the Japanese cohort. However, it is worth noting that the regimen was not exactly the same. Patients were randomized to carboplatin and paclitaxel standard dosing every 3 weeks versus weekly carboplatin AUC2 plus Taxol 60 milligrams per meter squared weekly times 18 weeks. This dosing regimen changed the dose density of Taxol, but not the intensity from the standard 175 or 180 dosing. Compare this to JGOG 3016 regimen, which did increase the dose intensity of paclitaxel by giving 80 milligrams per meter squared weekly. In MITO-7, quality of life and toxicity scores were worse than the standard every 3 weeks dosing regimen. Ultimately, the progression-free survival was not different between the 2 arms. While this study did not replicate the results of the JGOG study, given the toxicity and quality of life scores, this regimen is often used in patients that are more frail or who may not tolerate standard chemo dosing in an effort to reduce treatment-related quality of life and toxicity.
In 2022, ICON 8 was published to answer the question of dose-dense Taxol once again. This was a randomized controlled trial with 3 arms: standard dosing carboplatin and paclitaxel, MITO-7 dosing of carboplatin and paclitaxel, and then the dose-dense Taxol with standard carboplatin dosing. The third arm directly replicated the JGOG 3016 dosing. Unfortunately, no difference was seen in regards to progression-free survival or overall survival compared to the standard dosing arm. OPAL was a prospective cohort study published in 2020 out of Australia, which showed similar results. After the publication of ICON 8, dose-dense chemotherapy fell out of favor in the United States. However, dose-dense regimens can be considered if a patient is experiencing dose-limiting toxicities with the standard regimen as mentioned above. Epigenetic factors have been proposed as a rationale for why the dose-dense regimen was effective in the JGOG study, although the mechanisms are not fully understood. Some providers advocate for consideration of dose-dense Taxol for patients of Japanese descent or patients with clear cell carcinoma, which is a much more common epithelial cancer subtype in Japan. Although, again, we don't have a sound reasoning for this and should practice caution with race and ethnicity-based decisions in our treatment.
There were several investigations into whether the addition of bevacizumab to dose-dense chemotherapy could improve outcomes. GOG 262 was published in 2016, which compared carbotaxol plus minus bevacizumab versus carbo plus dose-dense Taxol plus minus bevacizumab. The dose-dense Taxol regimen was identical to the JGOG 3016 regimen, but 84% of patients additionally received bevacizumab. Overall, there was no difference in outcomes between the regimens. However, in the low number of patients who did not receive bevacizumab, the median progression-free survival was 14.2 months in the dose-dense regimen versus 10.3 months in the standard regimen. This data has not been replicated.
Taking these results into account, GOG 252 was published in 2019. It was a 3-arm trial comparing IV carboplatin with dose-dense Taxol and bevacizumab to IP carboplatin and dose-dense paclitaxel and bevacizumab to IP cisplatin and IP paclitaxel and IV paclitaxel on day 1. It's worth noting that the Arm 3 regimen has never been explored in other randomized trials and differs compared to GOG 172 in regards to a lessened cisplatin dose of 75 versus the standard 100 and length of paclitaxel infusion of 3 hours versus 24 hours. The study population included a high number of patients with suboptimal debulkings, making up 43% of all patients. All arms received bevacizumab during cycles 2 through 22. Ultimately, there was no difference in progression-free survival between the 3 groups. It's interesting to note that the median PFS is lower in this trial than in GOG 172 overall. This may be due to the protocol of CT scans every 6 months, so it's possible that recurrences were caught earlier than in GOG 172, where this scan wasn't a requirement.
Okay, so it sounds like in the US population, there haven't been any major practice changes to frontline systemic chemotherapy since the GOG 158 non-inferiority trial that was published establishing carbo and Taxol as the standard of care for upfront treatment of advanced ovarian cancer. With existing knowledge, how should we incorporate other agents into the complement of therapies for upfront treatment of EOC?
One way to add to upfront treatment is via maintenance therapies with different agents. The NCCN says the following. Recent trials have shown that maintenance therapy after postoperative platinum-based chemotherapy can have a positive impact on PFS in patients with advanced disease. So integration of maintenance therapy as part of postoperative management is increasing in prevalence and importance, end quote. Specifically, the NCCN is referring to SOLO-1, Paola, Prima, and Velia, all of which we will review later in this podcast. Let's go back to the early investigations of maintenance therapies. In 2003, GOG 178 was published. This compared 3 cycles versus 12 cycles of single-agent Taxol maintenance after complete response to initial therapy. It was found that maintenance or consolidation therapy significantly improved progression-free survival from 21 months in the 3-cycle group to 28 months in the 12-cycle group. Thus, the trial was closed early because of the significant difference, establishing the utility of maintenance therapy. Several other trials have evaluated incorporation of other agents as part of upfront therapy and/or maintenance. What are some of our options?
The utility of bevacizumab in EOC has been studied in several trials. GOG 218 was published in 2011 with long-term follow-up data published in 2019, evaluating upfront carbotaxol plus minus bevacizumab for patients with stage 3 suboptimally debulked or stage 4 disease. Eventually, patients with optimally debulked stage 3 disease were allowed in the study, but they weren't initially included. There were 3 arms to the study: carbotaxol versus carbotaxol bev in cycles 2 to 3. We're going to call that group the bev concurrent group, versus carbotaxol bev in cycles 2 to 22, the Bev concurrent plus maintenance group. The study found that progression-free survival improved from 10.3 to 14.1 months in the group receiving bevacizumab maintenance. Overall survival and the hazard ratio for progression or death was not different. Higher rates of hypertension and GI perforation were seen in the arms, which included bevacizumab. In the carbotaxol control group, there was a lot of crossover to bevacizumab at the time of recurrence. On long-term follow-up, the hazard ratio for death was not different between the groups, including in patients who received bevacizumab at crossover or as second line. The median overall survival for stage 4 Bev concurrent plus maintenance was 42.8 versus 32.6 months compared to the stage 4 control group. In the initial publication, the authors concluded that if a patient lacked a BRCA or HRD mutation, bevacizumab was associated with improved progression-free survival. This benefit was not seen in patients with BRCA or HRD mutations. However, in long-term analysis, they did not find BRCA status predictive of bevacizumab activity.
ICON 7 was published around the same time as GOG 218, with long-term follow-up data published in 2015. This study evaluated carboplatin and paclitaxel with versus without bevacizumab in patients with high-risk early stage and advanced stage epithelial ovarian cancer. Bevacizumab was given concurrently with the cytotoxic therapy and then continued for 12 additional cycles for a total of 18 cycles. Overall, the progression-free survival was statistically significant, but arguably of marginal clinical benefit with an improvement of 1.5 months. On long-term follow-up, the benefit of progression-free survival in the intention to treat group peaked at 12 months. By 24 months, the effect was no longer seen, and then actually became worse for the bevacizumab group compared to the standard group. However, in the high risk of progression group, defined as stage 4 or suboptimally debulked stage 3 or inoperable stage 3 disease, progression-free survival was 18 months with bevacizumab versus 14.5 months without, and overall survival was 36.6 months with bevacizumab versus 28.8 months without. Long-term follow-up showed a congruent overall survival in the high-risk subgroup, but no difference in the intention to treat group. The beneficial effect of bevacizumab in exploratory analyses suggested that patients with the largest residual tumor burden would most greatly benefit.
As mentioned before in the dose-dense discussion, GOG 252 and 262 evaluated the addition of bevacizumab and did not find a difference in outcomes. In 2023, the Oesch trial was published. It was a phase 3 randomized control trial evaluating whether extension of treatment duration with bevacizumab would improve outcomes. Patients underwent primary debulking surgery followed by 6 cycles of standard adjuvant chemotherapy followed by bevacizumab maintenance for 15 versus 30 months. There was no difference seen between the two arms. To synthesize the results of the above trials, it seems that bevacizumab is best for patients with, quote, high risk for progression of disease. This is generally defined as suboptimally debulked stage 3 disease, inoperable stage 3 disease, or stage 4 disease. Aside from putting patients into this high-risk category based on our clinical predictions, have any other models been developed to predict benefit from bevacizumab?
Yes, the KELM parameter, which stands for the modeled CA125 elimination rate constant K, or K-ELIM. This KELM cutoff is calculated by using at least 3 CA125 values during the first 100 days of neoadjuvant or adjuvant therapy. So it's thought to be a potential indicator of the tumor's primary chemosensitivity. Columban et al. Published a study in the JNCI Cancer Spectrum in 2020, evaluating the utility of KELM. They found that among the patients with high-risk disease, those that had a favorable standardized KELM of at least 1, which was 46.7% of patients, had no survival benefit from bevacizumab, whereas those with unfavorable KELM less than 1, which was 53% of patients, derived the highest overall survival benefit with an absolute difference of 9.1 months. This result was not statistically significant, but trended towards significance. Another study, the GOG 218 Kellam validation study, was published confirming the predictive value of the Kellam score. Kellam is the only validated biomarker we have to date for predicting the utility of bevacizumab. Okay, so let's say I have a patient that has biopsy-proven ovarian cancer with multiple parenchymal liver metastases. I know I'm not going to be able to achieve an optimal cytoreduction. What do I do then?
This is where neoadjuvant therapy comes in. Neoadjuvant chemotherapy can be considered for patients who aren't good candidates for upfront surgery. Reasons for this may include unresectable disease, frailty or poor performance status, and other medical comorbidities. The goal of neoadjuvant therapy is to reach a point where a patient could potentially receive surgical intervention, since we know that optimal cytoreduction is so important. My questions for you are, one, does neoadjuvant chemotherapy improve outcomes? And if so, which trials have helped us figure out when and how to use neoadjuvant chemo?
So, as you mentioned, we know that cytoreduction to the least amount of residual disease possible is really important. However, a significant proportion of patients have residual disease after primary debulking surgery. Since a lot of patients with metastatic disease have a good response to chemotherapy, there was a question of whether giving chemotherapy upfront could be beneficial. Initial retrospective data suggested that neoadjuvant chemotherapy was inferior to primary debulking surgery. However, these studies were thought to have a lot of selection bias. In 2010, the EORTC 55971 trial was published, and it compared neoadjuvant chemo versus primary debulking followed by chemo in patients with stage 3 to 4 epithelial ovarian cancer. Carbotaxol was the standard regimen, but other platinum-based regimens were permitted. The protocol specified that interval debulking surgery had to be performed as soon as possible after the completion of neoadjuvant chemo, no later than 6 weeks, and then restarted within 6 weeks post-op. Optimal debulking was achieved in 81% of patients with neoadjuvant chemo and 42% with primary debulking surgery. The hazard ratio for progression and death were both non-inferior. Notably, progression-free survival and overall survival were only about 12 months and 30 months respectively in both groups. Compared to prior trials, these were unexpectedly short timeframes. After this trial, the question still remained. If the rate of optimal debulking was increased, why were we not seeing a concomitant increase in overall survival with neoadjuvant chemo?
Several additional studies were performed to answer this question. The European Chorus study was published in 2015, evaluating neoadjuvant chemo followed by interval debulking surgery versus primary debulking surgery followed by chemo in patients with stage 3 or 4 EOC. Optimal cytoreduction was achieved in 24% of the primary debulking surgery group and in 34% of the interval debulking surgery group. Rates of adverse events and death within 28 days of surgery were higher in the primary debulking surgery group. Again, the progression-free survival and overall survival between the two groups were non-inferior, with surprisingly short PFS and OS overall. A pooled analysis of EORTC 55971 and Chorus supported the findings of the individual trials.
The Scorpion trial by Fagoti et al. Was published in 2020, evaluating neoadjuvant chemotherapy followed by interval debulking surgery versus primary debulking surgery followed by chemotherapy. The nuance with this trial was that all patients were taken to the operating room for a laparoscopic evaluation and assignment of a modified Fagoti score prior to assignment for primary or interval debulking. With this system, really high rates of optimal debulking were achieved. 93% in the primary debulking group and 99% in the interval debulking group. 46% of patients in the primary debulking group met criteria for a major complication versus 9.5% in the neoadjuvant and interval debulking group. Again, progression-free survival and overall survival were not different between the two groups.
The final analysis of JCOG 0602 was published in 2020, evaluating, like other trials, neoadjuvant chemotherapy with interval debulking versus primary debulking. Neoadjuvant chemotherapy again doubled the chance of optimal debulking, and no difference was seen in progression-free survival or overall survival. There's an ongoing trial called the TRUST trial evaluating neoadjuvant chemotherapy with interval debulking surgery versus primary debulking surgery that is expected to have results this year, 2024.
Okay, great. So what I've gleaned from these trials is that no trial can prove a progression or overall survival benefit of neoadjuvant chemotherapy versus primary debulking surgery. But it does seem to improve the likelihood of an optimal debulking and possibly will reduce the rate of complications and surgical morbidity. I'm excited to see the result of the TRUST trial. We've now gone through benefits of surgical debulking and lymphadenectomy, development of standard of care upfront cytotoxic chemotherapies, select utility of bevacizumab, and role of neoadjuvant chemotherapy. How do PARP inhibitors play into all of this in the upfront setting?
I don't know if you can sense it, Maya, but there's a theme here. Indications have changed a lot over time with a variety of trials, so let's just start at the beginning. We won't go through the mechanisms, differences between, or administration of PARP inhibitors today, but you can look forward to that in a future episode. Currently, there are FDA approvals for the following PARP inhibitors for upfront maintenance therapy: olaparib for germline or somatic BRCA mutation, olaparib with bevacizumab in germline or somatic BRCA mutation or HRD, and niraparib for patients with any BRCA or HRD status. As we discuss the formative trials, we need to consider how these trials defined the criteria for use. For example, homologous recombination deficient, HRD, versus loss of heterozygosity, LOH, versus BRCA mutated.
SOLO 1 was published in 2018, evaluating the efficacy of olaparib in the upfront setting in patients with advanced high-grade serous or endometrioid ovarian cancer with BRCA mutations. The majority of mutations were germline. It compared carboplatin and paclitaxel versus carbotaxol followed by olaparib for 2 years. The hazard ratio for progression-free survival in the olaparib maintenance group was 0.3, and the median progression-free survival was not reached.
The following year, 2019, PRIMA was published. Patients with stage 3 or 4 high-grade serous or endometrioid ovarian cancer with prior first-line platinum therapy with partial or complete response with or without a BRCA mutation were included. The study has a hierarchical design. It first analyzed whether the tumor had HRD via a BRCA mutation or a, quote, my choice score of greater than 42. We'll talk a lot more about my choice and HRD testing mechanisms in our future PARP inhibitor episode. If positive, they were moved to an intention to treat analysis. Patients were given niraparib maintenance for 36 months after frontline therapy versus placebo maintenance. They found the progression-free survival in the HRD population to be 21.9 months on niraparib versus 10.4 months on placebo. The median progression-free survival in all comers was 13.8 months versus 8.2 months. In an exploratory analysis of the study, in the HR proficient population, progression-free survival was improved to 8.1 months versus 5.4 months in the niraparib arm. It's important to note that the average patient in this study has a PFS of 5.4 months, which means that the average patient in this study was platinum resistant. This is different than the other studies and may mean that the baseline population here may be high risk or less generalizable when compared to other patients with high-grade serous ovarian cancer.
In the same year, 2019, PAOLA 1 was published. This study included all comers with stage 3 or 4 high-grade serous or endometrioid ovarian cancer or other non-mucinous histologic types if the patient had a germline BRCA mutation. The participants were tested for HRD via BRCA mutation or my choice score of greater than 42. They were stratified to carbotaxol and bevacizumab times 22 cycles versus carboplatin and bevacizumab for 22 cycles with olaparib. This was the first PARP inhibitor trial to include an active agent in the control group maintenance period. In the overall population, progression-free survival improved to 22.1 months versus 16.6 months in favor of the olaparib and bevacizumab group. This result was further emphasized in patients with BRCA mutations, with a PFS benefit of 37.2 versus 21.7 months, and in HRD of any kind, 37.2 versus 17.8 months. And finally, in the HRD positive but BRCA wild type group of 28.1 versus 16.6 months. There was no difference in PFS for patients with HR proficient tumors. The progression-free survival of adding olaparib to bevacizumab maintenance was similar between the two BRCA mutation types. From a safety perspective, the study showed that there was not significant adverse events of administering bevacizumab and olaparib at the same time, but the discontinuation rate was around 20%.
2019 was a big year for PARP inhibitors. VELIA was also published, which was a 4-armed study evaluating veliparib in the primary treatment and maintenance settings with a hierarchical HRD testing model. In this study, in the all-comer group, progression-free survival improved to 13.8 months versus 8.2 months with veliparib. The best outcomes were seen in all groups with chemotherapy plus veliparib primarily plus veliparib maintenance. These results were exaggerated in the BRCA mutation and HRD groups. At the time of publication, overall survival data was not yet mature, and this drug has not attained FDA approval at the time of publication of this episode.
Athena Mono is a study investigating rucaparib maintenance after frontline treatment with response. The preliminary results were published as an oral abstract at ASCO in 2022. However, this is not yet a published manuscript. In the abstract, the overall intention to treat group showed an improvement in progression-free survival of 20.2 months versus 9.2 months, and these results were exaggerated in the HRD groups.
In conclusion, it's important to remember that olaparib, niraparib, and olaparib plus bevacizumab are the only PARP inhibitor regimens that are FDA approved for maintenance treatment after response to first-line chemotherapy in patients with newly diagnosed advanced disease. These drugs are limited to patients with advanced epithelial cancer with a complete or partial response to first-line platinum therapy. The FDA indication for olaparib plus bevacizumab is limited to patients with HRD, and the FDA indication for olaparib alone is limited to patients with BRCA mutations. At this time, veliparib and rucaparib are not approved in the first-line setting. Now, why? Given that they have not published an overall survival benefit, the FDA has not approved these drugs. This criteria for approval is different than for previously approved PARP inhibitors. Athena has not reported overall survival data, but it's interesting to note that Prima got approval from the FDA based on its PFS data. You, as the gynecologist, should know that rucaparib is approved in Europe as frontline therapy.
Wow, that was a lot of information. It's time to sum it up. Here are our key takeaways from today's episode. Optimal cytoreduction, defined as less than 1 centimeter of gross residual disease, and ideally cytoreduction to microscopic or no gross residual disease, is the standard of care in ovarian cancer if feasible. This recommendation is based mostly on observational data, which shows improved overall survival with optimal resection, and even better when resection is R0. Retrospective and subgroup analyses of prospective trials have also demonstrated this improved OS benefit in patients that are optimally cytoreduced.
For advanced stage EOC, lymphadenectomy of clinically negative lymph nodes, i.e. not bulky, is not recommended. This is largely based on results of the LION trial, which showed that although systematic lymphadenectomy increases the rates of detection of microscopic metastasis, there's no difference in PFS or OS between patients by lymphadenectomy status. Bulky nodal disease, like all other growths, should be removed.
Historically, cisplatin and cyclophosphamide and then cisplatin paclitaxel were the standard regimen for the treatment of advanced EOC. GOG 158 established carboplatin and paclitaxel as the standard of care for treatment of ovarian cancer. Subsequent trials comparing carbotaxol to other regimens have not revealed superior efficacy, but different toxicity profiles, which are helpful to consider on a patient-specific basis. In this episode, we did not discuss HIPEC, but note that HIPEC at the time of IDS is an important treatment option. Coming up soon, we'll dedicate a full episode to HIPEC and IPC.
Bevacizumab is an important treatment option in the upfront setting for patients at high risk of disease progression or recurrence, specifically patients with stage 3 suboptimally or inoperable disease and stage 4 disease. This recommendation is based on the results of GOG 218 and ICON 7. The Kellum score is a validated predictive score based on CA-125 levels during neoadjuvant or adjuvant treatment that can predict response to bevacizumab therapy. Continuing bevacizumab beyond 15 months does not appear to have additional benefit based on the results of the BOOST trial.
Neoadjuvant therapy, giving 3 to 4 cycles of chemotherapy prior to surgery, has been shown in multiple prospective trials to improve the rates of complete cytoreduction and decrease surgical morbidity if radical surgery is anticipated to be necessary. 4 prospective trials have not shown that either neoadjuvant chemotherapy with IDS or PDS is superior to the other.
PARP inhibitors are approved for upfront maintenance therapy in a few settings. Olaparib is approved for patients with BRCA mutations being either germline or somatic based on the results of the SOLO-1 trial. Olaparib with bevacizumab is approved for patients with BRCA mutations or HRD based on the results of PAOLA-1 trial. Niraparib is approved for use in all patients that have a complete or partial response to therapy based on the results of the PRIMA trial. Despite positive trial results, veliparib and rucaparib are not approved for use in the frontline setting. And there is some data that use of PARP in the frontline setting may induce platinum resistance in the recurrent setting.
This has been another episode of Ready, Set, GYO, your source for all things gyn-onc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson. We'd like to thank Dr. Ryan Spencer, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.